Let's now turn our attention to the topic of older adults, defined as those adults greater than 65 years of age. Now, many of us have already heard that the number of men and women over the age of 65 is growing. If we look at this data from the U.S. Census Bureau, looking specifically at the older adults here, defined as greater than 65 years of age, we expect over the next several decades to see a large increase in the number of older adults within the U.S. population. So for example, those aged 65 to 79 years, over the next really 10 to 20 years, we expect to see a large increase from about, let's say 30 to 35 million now to upwards over 50 million within the next 20 years. And for those very old adults, those 80 and over, we also expect to see large increases in the number of very old adults within the next 10 to 20 years. Now, older adults who do not engage in physical activity typically see greater decrements in a number of physical performance measures and increase the risk of debilitating injury. Strength and conditioning professionals should understand the physiological changes that occur with aging, as well as the trainability of older individuals. Now, aging does not appear to enhance or reduce the ability of the musculoskeletal system to adapt to resistance exercise. Because of the age-related changes in musculoskeletal health, resistance exercise is a beneficial mode of training for older populations who need to enhance musculoskeletal strength and power and resist decrements in muscle mass, bone mineral density, as well as functional abilities. Now, significant changes in body composition with advancing age can lead to the development of physical functional impairments as well as injury. Advancing age is also associated with a loss of muscle mass, a term that is referred to as sarcopenia, as well as loss of bone mass, known as osteopenia. So both of these are largely attributed to reduction in physical activity with aging. So a direct result of the reduction in muscle mass as well as bone mass is a loss of muscular strength and power. And after age 30, there appears to be a decrease in the cross-sectional areas of individual muscles, along with a decrease in muscle density and an increase in intramuscular fat. So overall, the loss of bone and muscle with aging increases the risk for falls, hip fractures, and long-term disability. So if we think about some of the underlying factors here, in addition to aging, that may contribute to sarcopenia and osteopenia, a lot of that has to do with physical inactivity. So we become less physically inactive, or less physically active as we get older. But also there may be reductions in dietary energy intake as well as dietary protein intake with aging, and also a number of hormonal changes that occur with aging may contribute to the loss of muscle mass and bone mass in the older populations. So if we look at the effect of aging on skeletal muscle mass in both men and women, we see that approximately around 50 years of age, according to these data, we see a fairly steady or gradual decrease in skeletal muscle mass with advancing age. Now, as we would expect, this reduction in skeletal muscle mass with advancing age is associated with a reduction in muscle strength. So we see this gradual decline in muscular strength over the course of several decades here. However, in those individuals that are considered trained or active versus those that are sedentary, even though muscular strength does decrease over time, relative levels of muscular strength are still higher at each and every age category in the trained versus the active subjects compared to the sedentary individuals. Now, we know that bones become fragile with age because of a decrease in bone mineral content that causes an increase in bone porosity. Now, the bone mineral content, as well as the microarchitecture of bone, can deteriorate to such an extent that the risk of bone fracture, particularly the hip, spine, or wrist during a fall, is increased. So conditions which result in bones with less density and strength are serious concerns for older individuals, particularly older women, as they heighten the risk of skeletal fracture and poor bone health. So using a measure of body composition we call the DEXA, we can actually diagnose or determine a person's bone mass and use that to diagnose conditions associated with low bone mass. So the first one of these is osteopenia, and is defined by a bone mineral density between -1 and -2.5 standard deviations below the young adult mean. More severe is osteoporosis, which is defined as a bone mineral density below -2.5 standard deviations of the young adult mean. So what you see here in this picture here is clearly structural differences between normal, healthy bone on the left and a bone with low bone mineral density or osteoporotic bone. So if we think about some underlying factors and underlying causes here of low bone mass with aging, again going back to increasing levels of physical inactivity with aging, also reductions in energy intake as well as important minerals for bone health such as potassium, vitamin D, and calcium may contribute, but also a number of hormonal changes, particularly in women as they age. They lose estrogen, and estrogen has a very important role in terms of bone health. So if we look at this table here, again, typically using a DEXA, bone mineral density values are represented by a T-score. So this T-score, again, comparing the individual's bone mass against that with a young age and young sex-matched control subject. So we see a T-score here greater than -1 standard deviations, considered normal bone mineral density. And if we talk about low bone mass, osteopenia here, T-score between -1 and -2.5 standard deviations. And more severe would be a T-score greater than -2.5 standard deviations, indicative of osteoporosis. With a DEXA, we can really zoom in and look at bone mineral density in specific regions of the skeleton. So specific regions of the skeleton that are more prone to fracture include the femoral neck that you see here, as well as the lumbar spine. So if we look at the examples here of the femoral neck, we see in this 68-year-old woman, you see her T-score represented here by the arrow, and therefore she would fall into the normal bone mineral density category based upon her DEXA scan. Now in this 74-year-old woman, again looking at the femoral neck, here we have lower bone mineral density. This is represented here by the T-score here on the figure, and this woman would be classified as having osteoporosis based upon her T-score at the femoral neck. And if we look at the same thing here in the lumbar spine, which is also prone to fracture, we see in the 68-year-old woman, much like you see in her femoral neck DEXA scan, we see a T-score that puts her in the normal bone mineral density category. And in the 74-year-old woman, as you would expect, she has low bone mineral density in both her femoral neck as well as her lumbar spine. Now if we look at some data here in terms of projections of the number of people with osteoporosis and low bone mass measured at the femoral neck or lumbar spine. So here the red is going to represent low bone mass or osteopenia, and this is going to be osteoporosis here in blue. This is millions of people. We expect that over the next decade or so to see a fairly large increase in the number of people diagnosed with low bone mass as well as osteoporosis. So we think about what explains this projected increase in low bone mass over the years. Likely it's because more people, more older adults particularly, are being screened for low bone mass, but also because of better technology in order to detect low bone mass in those individuals. So as I've already mentioned, aging does not appear to enhance or reduce the ability of the musculoskeletal system to adapt to resistance exercise. Because of the age-related changes in musculoskeletal health, resistance exercise is a beneficial mode of training for older populations who need to enhance musculoskeletal strength and power, as well as resist decrements in muscle mass, bone mineral density, and functional abilities. Now, although aging is associated with a number of undesirable changes in body composition, older men and women maintain their ability to make significant improvements in strength and functional ability with resistance training. So aerobic, resistance, and balance exercises are beneficial for older adults, but only resistance training can increase muscular strength, muscular power, and muscle mass. So we see, according to the scientific research, that older adults who participate in progressive resistance training do show significant improvements in musculoskeletal health, whether that is assessed as measures of muscular strength, power, or muscular endurance. A number of studies showing that older adults show increases in muscle mass and fiber size with resistance training. Longer-term resistance training studies, typically those greater than 6 months in duration, show increases in bone mineral density in older adults. And also, resistance training has the ability to increase functional capabilities in older adults as well. So this one study published in 1999, they looked at untrained younger and older men. Those are signified here by the 30-year-old group and the 62-year-old group. All men did not have resistance training experience prior to enrolling in the study. And all men completed a multi-set whole-body resistance training program, 3 days per week, performed for 10 weeks in duration. So looking at the percent change here in 1 repetition back squat, so again as a measure of maximal muscular strength, we see that in both the young as well as the older men, significant increases in lower body muscular strength, on average about a 15% increase. Now if we look at muscle cross-sectional area of the thigh here as a measure of muscle hypertrophy, we see that both younger men as well as older men showed a significant increase in thigh muscle cross-sectional area, indicative of muscle hypertrophy with resistance training. Now they did see a slightly lower hypertrophic response in the older men that was likely explained by reductions in a number of anabolic hormones, including testosterone and growth hormone, in the older men versus the younger men.